from the LAPD interview that the jury's heard, you in fact found separate
and distinct extreme deviations from the standard of care. Yes. With each one amounting to gross negligence.
Yes, sir. You want me to name them, sir?
I think we'll go through them one by one.
Okay.
And you've listed all of these in your report?
Yes, sir.
Now, the first extreme departure or evidence of gross negligence you noted was that propofol was not medically indicated. Is that right?
Yes, sir. He was using propofol for the use of sleep. Propofol is, again, a very strong anesthetic medication, and we use it to facilitate, to make you comfortable during a diagnostic procedure. We don't use it for rest or for sleep or psychological reasons.
And on that issue of sleep and sleep care, did you note in your report certain requirements, aside from the propofol is not medically indicated, but just some basic tenets of sleep care?
Repeat the question, sir.
You indicated in your report that there requires discussion with the patient.
Oh, yeah. Before you give anyone before you do a procedure or give sedation, you need to get something called informed consent. When I do a procedure on you, which includes sedation, I discuss the risks, the benefits, the indications, and the alternatives of the procedure. Like that test I was talking to you about, the transesophageal echocardiogram, that the number one risk of that procedure is rather benign. The number one risk is really the sedation, because there's a risk of you stopping to breathe. So I always explain that and explain the risks and benefits.
And that issue of informed consent, written informed consent, that's a basic tenet of competent medicine, isn't it?
Yes, sir.
Where as you said, the risks and the benefits of the procedure are properly explained to the patient prior to going into the anesthetic or the procedure.
Yeah, and we want you to understand what's going to happen. And unfortunately, anytime we do a procedure or give sedation, there are risks, because when we give sedation, it can stop your breathing. You can obstruct your airway, meaning you can lose control of your throat muscles, and your tongue can move back and obstruct your airway. And also, you lose control of what goes into your stomach. I mean, what comes up from your stomach, it could go into your airway and go into your lungs and cause a dangerous pneumonia called an aspiration pneumonia. So when I do a procedure on you, I want to understand, God forbid something like that happens, I wanted to explain that was a risk to you.
And to your involvement in this case, and your analysis in this case, had you ever heard of any doctor using propofol in their practice of medicine to treat insomnia?
I've never heard of it.
And in your opinion, is the use of propofol as part of a doctor's medical practice to treat insomnia gross negligence?
Yes. It's indicated for procedures and patient comfort, not for sleep. That's extreme deviation from the standard of care.
And the second deviation you found was what?
A second deviation is that putting propofol, giving someone propofol in someone's home, unmonitored, without the proper equipment, medical personnel or backup, was also an extreme deviation from the standard of care.
Okay, and you've actually listed numerous things under that heading. So in the home setting without the proper equipment?
Yes, sir.
Without the proper personnel or staffing?
Yes, sir.
And without the actual physical observations of the attending physician?
Yes.
So let's go through these. And would each of these individually, although you list them as one extreme deviation,
yeah,
isn't it true that each of these individually would in fact be individual accounts of gross negligence?
I agree.
So let's talk about the lack of equipment.
Yes, sir.
And let's talk about that. What, in this type of setting, let's say in a hospital or an outpatient clinic or where propofol may be being used, what is the standard of care as far as monitoring equipment that is required?
Okay. There's quite a few things we're going to go over.
A little bit vague. There's no clarification as to the type of sedation.
All right, I'll sustain the objection. Refine the question, please.
In regard to the standard of care, as to the use of propofol, okay, when propofol is administered to an individual, what is the standard of care as to the appropriate monitoring equipment that is required?
Okay. The standard of care for someone who's getting propofol should be monitored. There's a lot of things that you need to have monitored in a lot of different types of equipment. First, you need a pulse oximeter with an alarm, meaning a pulse oximeter. I think you guys got a lecture on that, right?
We're not going to have a dialogue with the jurors.
Okay.
So just,
Sorry.
please answer. That's okay. Please answer the question.
A pulse oximeter with an alarm.
Pulse oximeter with an alarm, and you want to check it checks the oxygenation in the heart. And if it gets to be a low level, meaning the oxygen is low, then that's concerning, and you want to have an alarm saying, help, there's a problem. Dr. Murray's machine did not have an alarm. And so if you can imagine, if you have to monitor this person the whole time, you have to be staring right at that machine every second while they're on sedation and on propofol. So that was grossly negligent and extreme deviation of standard of care.
In addition to the pulse oximeter, what is the standard of care type of equipment that is necessary?
Okay, so he did have IV equipment, but he did not have an automated blood pressure cuff. That's a cuff that checks your blood pressure so you don't have to do it yourself. He did have a manual cuff, but it was not in use. You should be checking the blood pressure while getting propofol every 5 minutes at least. And that was not done.
Is there more equipment that is required?
Yes, okay. The next thing you need is an EKG monitor, so we can monitor your heart rhythm, make sure nothing bad arrhythmias occur. He did not have an EKG monitor.
And how does the EKG monitor work?
You put electrodes on the chest, and then we can see how the heart rhythm is on a screen. So if there was a normal rhythm, you could see it, and if there is extra heartbeat, sometimes that can be an early sign of irritability. And when the patient starts to get low oxygen, the heart starts to be stressed, you can start having arrhythmias. And so you want to have a monitor in order to monitor arrhythmias.
In addition to the blood pressure, the pulse oximeter, and the EKG,
Yes.
what additional equipment?
You need oxygen, and he did have an oxygen. I don't know the exact oxygen supply he had, but you should have various types like nasal cannula through the nose or a mask. You need suction, because as I told you, you can regurgitate things into your mouth. Suction is what you see at the dentist when he sucks out your saliva. You want to have that so in case someone regurgitates, the nurse can quickly go in there and suction out these things from your stomach before it goes into your lungs. The other things you need is a bag mask or an ambo bag, and you need to know how to use it. An ambo bag is a oxygen mask. It's connected to a valve, a large air chamber that looks like a football. And what happens is you can give positive pressure oxygen. You put the mask on, and you can push oxygen into someone's lungs. Dr. Murray had an ambo bag, but he did not use it.
And you're taking that from his own statements where he states that he did mouth-to-mouth the patient, but makes no mention of using the ambu bag.
Yes, he gave mouth to mouth and he did not use the ambo bag, but on a picture I saw that there was an ambo bag on the floor. The next thing, which is probably the most important, is a way to summon for help. When we give sedation or do a procedure, we either have a nurse that we can have call the rapid response team or the code team, or we have a button that we just press and the cavalry comes over to help us.
What do you mean by the cavalry?
Well, usually it's multiple nurses, a respiratory technician, sometimes an anesthesiologist or a emergency room doctor who's adept at fixing someone's airway and intubating the patient.
And any other required equipment for this area that you're talking about, the monitoring?
Well, one documentation we'll talk a little bit later. You need a good room with nice lighting. You need a backboard. Everyone has a backboard. That is a hard surface board that we can put underneath the patient. God forbid the patient has an arrest and we need to give CPR. The patient's usually on a soft bed. And when we give CPR, we have to push down with our two hands 2 inches down their chest. And if we do it on a soft bed, we're just going to displace the patient down 2 inches. So we put a backboard underneath them in order prior to doing CPR. The other things you need is a backup battery. We had in Ventura County, we had a blackout about a month. I know there was one in San Diego. God forbid you're sedating someone and the lights go out, you should have a backup generator.
And that would be for the various equipment you described?
Absolutely, the pulse oximeter, the automated blood pressure cuff, because if the lights go out and your patient becomes hypoxic, you may not know what's going on. God forbid they have an arrhythmia, you don't have an EKG monitor, you can't defibrillate them because the defibrillator will not be on. The other things you need, the other things you need is an oral pharyngeal airway. I told you how sometimes the tongue can slip back and obstruct the airway. It's a little device that keeps the airway open. And then very important, it's utmost importance, you need equipment to rescue the airway, like a tube to put down people's throat into their trachea and lungs, just in case someone stops breathing and you use the bag mask and it doesn't help. We need to be ready to intubate the patient. So you need to have that nearby.
And that's an endotracheal tube?
Endotracheal tube, yes, sir.
And that would also, when you're administering propofol, you would have to have someone trained to also be there to manage the endotracheal tube and get it put into the patient, essentially.
Yes. Yeah, we usually, again, we only use mild or moderate sedation when we're a cardiologist, but sometimes in the procedure, the patient can get over-sedated. They usually don't over-sedated. There's equipment is still in the room, and an anesthesiologist or emergency room doctor with the press of the button can come over within a minute or two and intubate the patient.
And Dr. Steinberg, you indicated they can become over-sedated. Usually not, but they can. That's a foreseeable, likely consequence.
Absolutely.
And that's this continuum where a patient can actually cross from, for example, light sedation or into moderate sedation, and you can pass from moderate sedation into deep sedation, and that's one of the dangers and risks that you need to be prepared for, correct?
Yes, sir. And absolutely. With propofol, I understand it has a very narrow therapeutic threshold, meaning you can go from one edge to other quickly.
In addition, then, you mentioned the airway management equipment, the endotracheal tube. Any other equipment?
As I said before, there's a defibrillator. That's a special machine that we shock people's heart back to normal. There should be a defibrillator, and it should be on, ready to use. The other thing is you need a lot of special drugs when we're giving sedation. He had one of them called flumazenil, which is a reversal agent for benzodiazepines. That means it's an antidote to benzos. Those are one of the required ones. The other ones are Narcan that reverses narcotics. If someone has an arrhythmia, we should have amiodarone, lidocaine, beta blockers that can stabilize the rhythm. If the heart rhythm is too slow, we should have atropine to increase the heart rate. If the blood pressure is too low, we should have medications like dopamine and epinephrine in order to increase the blood pressure. If there's an allergic reaction, we should have prednisone. If the sugar is low, we should have dextrose.